This all seems like it's all totally directionally correct, and I get the part about the insurance people and hospitals pushing the wrong direction. But that being said, why don't we, if this is as good an idea as it seems to be, and you guys seem pretty passionate about it, sounds good to me, why aren't there more doctors flooding and pushing in this direction?
I guess as a doctor, I'll handle that one because doctors in a general way are sheep. And they're focused on their patient. They're not involved in politics at all. They have this professional calling where they think all of this other stuff is beneath them, and it's only about the medical science of taking care of the patient. And so every time this stuff happens, we're just sitting there like, what? And it happens, and it just keeps going step after step after step. And so now, I can just tell you, I have students and residents with me all the time. They all now want to be employees. Right? They think the idea now is, hey, I'm going to go out and have a 9-to-5 job, and I don't have, it's too complicated. And this is the point of the bureaucracy, is they make the bureaucracy so intense that the small practices have a very difficult time surviving, so they can't go out and do what I thought I wanted to do, which was to be a small businessman and professional. So that's gone by the wayside, and they say, I can't set up all these complicated things. I can't learn about HIPAA. I can't
Isn't
learn.
that all the more reason for them to push for this?
Oh, absolutely, but in part, though, they've already selected in their mind that they want to be employees and have a highly paid job, 9 to 5. But, and now, as I mentioned, MCATs, the screening test to get into medical school, is going to now start screening for people who have the orientation toward the bureaucratic method of taking care of the population instead of the individual patient. So it's
George Orwell.
yeah. Oh, it's
Right.
Thank you. Thanks for being here, Dan.
Thanks, that was a great question. More of that bureaucracy is really this favored nation clause that CMS prevents doctors from they would challenge this model if you're also taking care of Medicare and Medicaid patients. So we're kind of at risk for that. Tom could speak a little more about that. But that's one of the reasons why, and I told Pat this, I said, Pat, this is a great way to get legislators behind to say, look, you want to increase access for Americans to get health care, you got to get rid of this favored nation clause from CMS that says, well, wait, if you're taking care of any Medicare and Medicaid patients, you can't have this different model. Even though this legislation says that model's fine, there's other sources in the government, more bureaucracy, that prevents that sort of competition.
So the law is right now, if you're a physician and you want to offer direct primary care to someone on Medicare or Medicare age or on Medicaid, you have to opt out of Medicare for 2 years. So you're a physician, you have a full patient panel of 2,500 to 4,000 patients, and you're seeing 25 to 40 patients a day. You're making decent money. You're upset with your life, but you're making decent money. And now someone comes to you and says, if you want to treat those Medicare patients in a direct primary care fashion, you have to opt out of Medicare for 2 years. So that physician says, well, what if it doesn't work? What if it doesn't work? Am I going to walk away from my patients? Am I going to walk away from my current practice? So there's many more legal issues that we need to fix, and also they need to know that patients are going to stick with them and pay the fee, pay the monthly direct primary care fee. So,
and I went through that kind of quick earlier, but that's part of that federal strategy, that Senate concurrent resolutions, that number 5 that I was talking about, that opens up the door for Medicaid and Medicare usage of direct primary care services, is a key push that we're working on right now. I have, just so you guys know, we're in the 11th Congressional District. I have contacted Congressman Trott's office. I've talked to one of his legislative aides about what we're trying to do in this context. He's aware of everything that we're talking about tonight and the need for what we need to do up at the federal level, especially since we control both houses on it. It would be nice to be able to open that up. And I believe it should be a bipartisan opportunity here because this is good for all of our citizens. But anyway, we have an opportunity. If you want to contact Congressman Trott's office and just advise him that this is something, I think Carol Ann, General Fazzone's here from Congressman Trott's office. Is she still here? Okay, she was here earlier. But if you're interested in what you're hearing today, please just provide a note of support out to Congressman Trott's office and say, guys, this really sounds like the direction we need to be headed. We can use some help on this as well. I think they're ready to roll on it, but it helps to get encouragement. So, and Dr. Lee, you're great to see you.
Hi, I'm Dr. Stan Lee. I'm an orthopedic spine surgeon who has broken out of the insurance system and opted out of Medicare. And thank you all for presenting today. I think it's awesome. We've talked a lot about preventative care tonight and the value of preventative care, and also elective care with Oklahoma Surgery Center, for instance, providing elective care. But my question to the panel is more about catastrophic care. Because no matter how good medicine is this day and age, we still haven't cured the problem of people getting sick and people dying. And if you look at every American in here, at some point we're all going to die. And at some point, many of us may have a catastrophe or a catastrophic illness. And there's a huge sucking sound right now at the very top of the pyramid from places like University of Michigan or Cleveland Clinic or Mayo Clinic that provide these very high-level services that are critical to our society, like transplant surgery, neurosurgery, for instance. Now, as an orthopedic spine surgeon, I spent 4 years at the University of Michigan. I'm full-time faculty there. And I saw firsthand the negotiating power of a transplant program. And that's something that cannot be governed by free market principles because, number one, it's a highly, highly scarce resource. And number two, when you have somebody with a bleeding aneurysm of the brain, it's a local product. You can't shop that. And so how do we control costs without capping those high-level services that aren't really subject to free market forces that we all need? Or if somebody's in a trauma, for instance, tomorrow, a 25-year-old healthy guy could get a trauma, and they could have $1 million worth of care over the next 6 months. How do we solve that issue before we start dealing with things like elective surgery or primary care that really, primary care, for instance, for a 25-year-old might carry a much different value than an 80-year-old with chronic conditions.
I'll try.
No, actually, yeah, you're perfect for this.
I'll try. This is a hard question. First, the whole healthcare space is very, very complex, and it requires great humility, great thought, and even some theology in terms of the question that you've asked. Meaning that part of the question that you've asked is, do you actually care for some people in certain circumstances, and what's the cost to them? And that's not the purpose of this discussion, and to have a long conversation about death and dying and those issues. What we can say is that when we look at a health plan, that's one way, that's the way I'm taught to think about things. I'm taught to think about populations of people and how do you drive the greatest value, the greatest well-being to that population of people. Now, a population is made up of individual people. That's the thing that people forget in my business. So they look at the bucket of water, but they don't remember that it's made up of drops. Okay. What we do know is that 80% of the cost of healthcare is lifestyle related, meaning that I can impact my health and well-being by not going necessarily to McDonald's every week, right? And not smoking cigarettes. Or on the other side, I could be out exercising and maybe going to Whole Foods or some other nutrition or exercise. So part of my answer is that if we can create a healthier society that understands the needs of caring for those that are no longer a health control issue, i.e. the variable risk of an aneurysm, okay? We'll have more resources to do that. But like the good doctor said, some of those things are variables in the marketplace, i.e., I can't get that organ donated to save that life. That's a reality of human condition. You as a doctor are not going to solve that problem, and I think you related that to the audience here. So the question is it is true, is how do you become as compassionate or fully passionate in caring for those greatest in need? One of those ways is, in fact, for us to be in a marketplace that takes on direct and active responsibility for your health, so that I'm the least burden possible to the rest of the population, and that those that have the greatest need, that are beyond the ability of responsibility, are cared for. Let me give you an exact point of this. And we talked about this in pricing, right? And price transparency. Believe me, if you look at all the data, and I've been in this business for almost 40 years, you can tell by the face, okay? always the lowest cost. Now, when everybody makes an absolute statement, understand that that's true 99% of the time. But quality is always the lowest cost. Meaning that if I go to a more expensive doctor for a particular procedure, it may in fact be the lowest cost because I don't have readmittance, I went to the best provider. Yes, it was more expensive on that unit cost basis, but on the episode cost basis, it's the lowest cost because I got the quality care. The same is true that I could see a doctor that has a lower cost and not knowing that it's really the highest quality. In fact, the more expensive doctor doesn't have the same quality metrics as the lower doctor. I want to go to quality. When we just show cost, we get confused because we can sometimes miss the fact that we're actually not going to the right quality. So one of my arguments has always been we need to really focus on quality indexes, and cost indexes are secondary because in the end, we'll have the lowest cost. In that context then, we do a disservice to the American people by showing them every time about a particular point of care being a lower cost, but it may actually be a higher cost in the end because it's not quality. My point to that is that when we understand what is true, we'll create more resources for that top of the pyramid that needs to be cared for, right? Now that does not address the theological issue that we're all discomforted with, is that we're all going to die, right? And as a society, we need to get more comfortable with that. Because the truth is, and I've seen many people die in the last few days of their life, and guess what? All the hospitals have to now say, no matter what the situation was in care, including the fact that your mother or father passed away, or someone in the family passed away, is you have to complete a survey and say, how is the quality of the care? They died. But you know what? The nurse loved my father. The nurse showed care. What else could they do? Right? But so we need to get comfortable with that the care system that we have is compassionate and focused on the individual. And part of this whole discussion is to say that one of the attributes, at least in primary care, that we can address is to reconstruct the patient-physician relationship in a meaningful way where there is human compassion engaged in a direct relationship, not a settlement meeting. Okay? So it's a complex question, very complex, lots of pieces to the answer, but that's a component of the answer.
I'd like to comment too on that. Stan, thanks for bringing that up. That's a great question. And you hear this all the time. And this is exactly what the insurers, they love that question. Because then they're going to tell you, well, what you need to buy is a health plan for every eventuality. But honestly, my answer is that you could buy reinsurance for anything. You could buy reinsurance for a hole-in-one. You could buy reinsurance for lotteries. There's reinsurance policies for every eventuality. In fact, Americans are buying a reinsurance policy for the insurers in the Affordable Care Act. So they hedged against adverse selection, right? So we're paying, what percent is our tax on that? 2 something. So we're buying a reinsurance plan for that. And so my answer there is that we fall for this never ever events kind of thing. And the truth of the matter is we very rarely need those services, most Americans. We're going to have one bad year. We don't know which year that's going to be. Probably when we're a little bit older, hopefully, God willing. But we're going to have one bad year. That's why we have insurance. We shouldn't be buying health plans that say, hey, give us your money, we'll take care of everything, from changing the tires and getting your wipers fixed and your physical exams to, what if you have a bleeding aneurysm. And I think what we can do is, as a society, we can have a little more competitive environment, just like they do in Switzerland, and they have these centers of excellence where they'll send those folks to them eventually, if they can get stabilized enough, get them to the Mayo Clinic or what have you, if they're going to specialize in aneurysm clippings or Cleveland Clinic, you name it, just like Walmart did, right, for their elective surgeries. Now, those aren't emergencies, I agree with you, Stan, and you have to have local regional centers of excellence that do those things, but those are rare, never-ever events, so you don't need a lot of them. And we can devise a reinsurance plan that all Americans can contribute to, that buy health insurance, that covers for those never-ever events. But our basic health insurance plan shouldn't be, should be a fraction of that, not all of that.
And I'm going to kind of dovetail a little bit on what David was talking about on the theology aspect, except a little bit different context. And I've hopefully you've kind of heard the theme that I have a lot of faith in the free market. And we're talking about a constrained resource for catastrophic care, right? I'm going to put on my gearhead hat a little bit here. As an engineer, I know that there's technological advances that are happening across the board, and in particular in bioengineering. And one of those advances is around the area of 3D printing, where they can actually print replicated organs using your own cells grown in a substrate or whatever with it to be able to implant back in your own body. So in a way, when you start looking at if something's constrained, if there's a demand for something out there, we're going to have somebody out there. I'm confident in the country we live in. As long as we make it an opportunity for somebody, I think somebody's going to provide that supply. So it's a little bit off the wall. It's a little bit kind of out there right now, and obviously it's in the formative stages, but it's something that's starting to show a little bit of promise for some people and in the area of that catastrophic care. So nothing's always constrained. You get that demand up there high enough, and usually somebody will find a way.
Just to support that, every day is another day in the healthcare space, so it's always an opportunity to grow. Today I had a visit to one of the local manufacturers of medical supply, and he shows me, we can make this part for the human body at 30 to 40% below the market price. Here we are, this company out of Royal Oak, Michigan, not located in Royal Oak, Michigan, and not Royal Oak, Michigan, originally they were now in Rochester Hills. But the point is, Senator, right? Here's somebody saying we can do this, but you know what the deal is, right? The reason they can do that, exactly. They're not messing with this. They're trying to go directly to the physician, not go through the hospital, and not go through Pfizer or whoever it is. As a distributor, they're trying to go directly and say we can bring this directly to the doctor who's performing that surgery. We're at a 60-70% discount in this piece of equipment. And so the marketplace does work. We just have to allow it.
Exactly. Yeah.
So one quick dollar comment, just to maybe make some of this a little more clear. We were talking about the quality and care thing, and the quality is always tough to get at, and that's the big challenge now. But the real key here is price transparency. I was just showing Senator some numbers from Oakwood for an MRI. Same machine, same parking lot, same tech, same doctor's reading. People paid between $380 and $2,800 for the exact same thing, depending on who's paying, whether it's you, which insurance company, this sort of thing. So that's one aspect of that cost and payment system in healthcare that's totally broken. The competition will help overcome the price transparency. Another example is something that has to do, again, with this whole hospital thing. Cardiologist, if you got a stress test in our office, it costs X. If you got the exact same test in the hospital, it costs about 1.9X. If you got that same one at the University of Michigan, it costs about 2.7X. Exact same test. Now, the way the laws have changed, you would think in a normal system what you would want to do is we're doing it for X, not 1.9 or 2.7X. Well, let's encourage the guy who's doing it for X. Well, what they did is they cut payment to us, driving us out of business to be employed by the ones doing it for 1.9 or 2.6. And so now the patient used to come into my office, exact same office, exact same machine, me still looking at it, same tech, now costs twice as much. Because the way the bureaucracy wants it to operate is to funnel everything into one system, even if it costs more. Because once they get into the cost system, then they can close the spigot and have complete control over rationing. So the whole idea of this direct patient care, obviously, is to get outside that. But when we're talking about an average of perhaps $100 a month or $1,200 a year for your care, And now under the new system, we might have an insurance program for a family that costs $15,000 or $18,000, and you still have a $6,000 deductible, right? So you potentially have $20,000 pretty easily. In data from the insurance industry, on their payment of claims, 95% of the insured have claims less than $5,000 a year. So we have 95% of the people paying these $15,000, $18,000 premiums and deductible potentials, when the insurance companies already know that 95% of the people are going to cost them less than $5,000 or $6,000 a year. And that is why, of course, there's no public option in the Affordable Care Act, is because it was written by the private insurance industry.
Good evening, everybody. I want to get back to primary care here a little bit. I'm in my 60s. I've been going to a primary care physician in Ann Arbor for many years. She abruptly quit, got a letter just at Christmas time, and you will be assigned a new physician. So I thought to myself, okay, usually what I like to do is check with friends, family, where they go, and because that's typically I'm a healthy woman, and more often that's who I see. So many of my friends say, well, my doctor's not taking any new patients, and my doctor's not taking any new patients. Maybe I'm making more of a statement, but I also want you to comment on this. We just built, or we didn't build, the University of Michigan built a health system, the Northville Health Center, a two-story, 100,000 square foot, 35 million facility, one-of-a-kind health system. It's going to supplement the 2 Livonia clinics. Fully operational, the health system will service more than 715 patients. So I asked a physician, she's an eye doctor, who just moved to the facility, about a primary care physician, and she said, oh, you won't get one, we only got one. Okay. Because I live in Plymouth. And I thought, well, instead of going to Ann Arbor, it makes sense to go to this new Northville facility. So if you go onto the website, and I was just Googling this as I'm sitting here, at the present time, the general medicine clinic at the U of M Northville Health Center will only be seeing those patients who currently have a relationship with a general medicine physician at our Livonia Health Center. New patient appointments will not be available until further notice. We regret any inconvenience this may cause. So, I guess I'm asking you, is there a crisis with finding good healthcare, primary care physicians? And I guess I'd just like you to comment on that. We've got, and I guess I'm looking at this pyramid and wondering, all of these specialties, and I took a friend over to the healthcare center, and she went in for very specialized care, the Northville Center. And it seems to be lots of employees, but lots of specialty care and subspecialty care going on there. So what does one like myself do? Would you like somebody comment, please?
I'll take that one. It's a great question, and there absolutely is a crisis in primary care delivery in this country. The reality is that we need 2/3 more primary care physicians and 2/3 less specialists in the system. The Physician Foundation study done a few years ago said that 50% of primary care physicians are going to retire or leave medicine. Dr. Steele wasn't too far off. I believe that what's going to happen is the next round is, with all of the things happening in healthcare, is that the specialists are going to really start being hit hard. And we're seeing it in cardiology and a lot of other specialties. And if direct primary care really takes hold, that could be the solution. Because when you have a lot of specialists, they're all trained as interns. And if the system really needs 2/3 less specialists, they're gonna turn around and say, you know what, I could actually practice primary care and do as well as I'm doing now in my specialty. Not only that, but you're going to have a lot of primary care, there are a lot of students who decide to go into primary care because they could actually practice medicine the way that they really view a physician to be, is practicing it, in general practice. If you talk to a lot of medical students and you said, what was your favorite rotation during medical school? A lot of them, the majority of them, will say family medicine or pediatrics or internal medicine was by far my favorite rotation. And then you say to them, well, what are you going into? Well, I'm going to be a specialist. I'm going to go to dermatology or whatever. And who can blame them? They're coming out of medical school with $100,000 in debt, and they know that primary care hours and what we make will allow them to pay that off. So I think that if this model does take hold, that could be the solution. But right now, you're going to see it actually get worse, and it's going to be almost impossible to find a primary care physician. The system solution to that is where one doctor will take care of 2,000 patients and supervise 5 nurse practitioners or PAs who will each take care of 2,000 patients. That's the only solution from the traditional standpoint. So we don't think that's the right solution, and we're trying to make a difference. That's it from a long-term solution or from a solution systemically. But you need an answer, right? You need an answer, who am I going to go see? My view is that the concept of direct care makes a lot of sense because it's a secure relationship. And, let's say it costs you $2,000 for a relationship. Let's say it costs you $3,000 for a relationship, whatever it is. When you think about your health as your most valuable asset, what are you investing in every day, right? And it is $2,000 too much to invest in a relationship and have a lot. My health insurance costs $18,000, right? What does that do for the average person? Because we're talking about, I'll throw out another number. For the 70% of the population incur less than $1,000 cost. You're buying something for $18,000 for the family, and for you as an individual in that family, 70% of you will incur less than $1,000 in cost. The point is that if you were closer to Troy, or if you wanted to travel to Troy, call Dr. Blanchard. If you're closer to Ann Arbor, I have another doctor, Rusty Shavy, who would be happy to talk to you. Meaning you got to find these people now, and you start to move there, talk to your friends, and start to get them to go to that direct care physician. And then it begins to perpetuate itself. That's why we're going to be working with employers to try to get that moving.
All right, I think we're going to wrap things up here. Just to put an exclamation point on that discussion around the physician shortage that we're starting to face right now. If you work with the assumption that and the figures that I've seen around how much time in a typical primary care physician day is actually spent doing administrative overhead type tasks, doing things like CPT coding, running the office, that kind of stuff. If you take the assumption it's about 50% of their time, the nice thing about this model is if you were to deploy it nationwide, you effectively double the number of primary care physicians without graduating one more new doctor, without retiring one more new doctor throughout the country. So it's another way of looking at if you can increase the throughput and get rid of all the baggage, all the things that are, I like to say, the cholesterol of the healthcare system here, all that administrative overhead. If you can clean up the arteries and increase the throughput, that's another mechanism, one of the reasons why I'm so excited about this direct primary care model. So we covered a lot of ground tonight. Thank you for your patience. This isn't the easiest topic to cover, as you might imagine, and so we tried our best to kind of digest it. These folks here, David, John, Tom, and Rob, and Matt, when we're going off and promoting policy at the state level, I mean, I'm not an expert in any of this stuff here, and I'll be the first one to tell you, but it's great to be able to have these guys on speed dial and be able to call them and say, does this make sense? And so I really appreciate you guys getting us to the point we are right now in the discussion, because without you guys, we never would have been here. So thank you very much for your dedication.